some other name.
Okay. So I will start. So good morning. Thank you all for joining us today. We are pleased to be able to welcome those of you that have been with us in the previous group meeting last month, as well as those of you who are new to our Axios and Amper Clinic group meeting. Yesterday marks as World Psoriasis Day, which is on 29th of October, and we are very proud to be able to make it with all of you today. So just before we get started, I would like to express my gratitude to all of you who so generously help us to make this group meeting today. Our speaker, Dr. Kirthi, Dr. Vigil, and Dr. Siri Kumar. And let's start to welcome Ms. Diba. So good morning, Ms. Diba.
Good morning to all of you. Thank you so much for coming over online for this psoriasis group meet, I should say, inviting all of you guys. Thank you for joining us. Every year on October 29th, we celebrate the World Psoriasis Day. Basically, this day is meant for creating awareness about the autoimmune disorder. And this year, the theme for this World Psoriasis Day is to be informed. Basically, we are trying to say is that psoriasis is not contagious. It's only an autoimmune disorder. And that, it's when the immune system starts attacking our own body, when our own skins are affected and inflammation starts coming up. So basically, it's a struggle for many of us. I'm a psoriasis patient for the last 15 years, and things have been difficult for me in between as well. And I'm sure many of you guys have going through different struggles of your own. So this day is basically for you guys to say that, we are not alone. We are together. It's a disease that we all have to fight together. It's not a cosmetic disease. There are a lot of other implications to this disease as well. And it's important that we are well informed about this disease and not just keep hiding it and thinking it's only a skin disorder. There is more to it. And this day is basically to let every patient know that, being together, let's fight it out mentally, physically, however struggles that you guys are having, let's face it, we all need each other's support. Probably the people around us may not understand what we're trying to express. Our skin shedding might be a small thing for them, but it's more to it. It affects the quality of our life, and we need support. And support from another patient, support from friends within the group, support from a doctor, little words from cheering up from the doctors, from people around us, makes a difference for each one of us. It makes, for me, I'm sure it makes for every one of you. Just call up, just discuss anything, any issue. The doctors are there. We all are there for all of you people. So let's be together and. Along with Amber Clinic and for the Axios group, I'm actually thankful that you guys are holding this event because this means the information is coming to us at a very faster pace. Unless, not like we read and we take in the effort. This effort from both the sides means a lot to us. And so thank you to everybody who's joining us, and thank you to the doctors who are giving this presentation for today. And thank you, Axios, for actually arranging this event. Thank you so much. You can carry on.
Thank you, Ms. Diba. So here is Wayak team, Wissam and Asma, Lina, and myself, Marwa. So I will start with the journey of the patient with psoriasis. So your journey begins once signs and symptoms associated with the psoriasis, like red scaly patches covering the skin. So your dermatologist doctor will examine your condition using different diagnostic tests. So once the condition is confirmed, the doctor will prescribe for you the suitable medication for your condition. Briefly, I will speak about the access to treatment. The programs Shukran and Musanada program. Both are cost-sharing patient assistance program to support patients who face affordability barriers in obtaining their medication. Shukran is defined by a patient with a co-payment insurance who is facing difficulties in covering their share. Musanada is defined by a patient having no insurance or insurance with no coverage or insurance with a budget limit. And Wayak program, Adherence Patient Support Program, for all the patient prescribed Cosentyx, where the patient will be supported from different perspectives. Disease and medication awareness and education materials will be provided to the patient, proactive follow-up calls, reminder with the injection and appointments, refill, and as well insurance follow-up and emotional support. And the next slide, it will speak about the World Psoriasis Day. Was established in 2004 by a Patients for Patients. International Federation of Psoriasis Association has announced that 29th of October each year as a World Psoriasis Day, and it connects 125 million champions and fighters who's beating psoriatic disease in global to raise their awareness and and improve their access to treatment. So my colleague Asma will continue to speak about the World Psoriasis Day. The floor for you, Asma.
Yeah, hello everyone and welcome to our online meeting. As Ms. Deepa mentioned earlier that every year World Psoriasis Day they have a specific theme, and for this year the theme is to be informed, because informed individuals they can manage their psoriasis better and they motivate the behavior change in their communities. So World Psoriasis Day, it is dedicated to people living with psoriasis and psoriatic arthritis, and it aims to address their needs. So the first aim is to raise awareness. Psoriasis, it affects millions of people around the world, and it does not just affect them physically, it also has an impact in their socially and also financially. So World Psoriasis Day aims to raise the profile for this disease and increase the awareness of the effect it has on people's lives. Axios implements the WHO 5 dimensions of adherence through the adherence program WIAC. WIAC, it provides different services for patients who are prescribed with the medication Cosentyx. Given that each patient journey is unique, WIAC is designed to address patient challenges in a personalized way. WIAC offers a range of services to support and optimize the adherence throughout the patient journey. These services, as my colleague Marwa mentioned, they are disease and medication information. Also, it provides emotional support, follow-up calls, and face-to-face meeting and insurance follow-ups. Okay, so for many, psoriasis is still a relatively unknown disease. World Psoriasis Day, it aims to spread information about psoriasis, to dispel the common myths and misinformation about psoriasis. So patients, they should know about their own condition so they can feel empowered to speak about it. Some of the most common myths and misconceptions that people think they are facts is that psoriasis is a skin disease. Psoriasis is actually a severe chronic non-communicable disease, as Ms. Deepa mentioned earlier. And some of the myths also that psoriasis is contagious. It's not contagious, visible. And also one of the myths is that psoriasis is easy to diagnose. The fact is that many skin conditions, they do look kind of alike. So a specialist and a dermatologist can only examine the patient and do all of the diagnostic tests to confirm the condition. One of the myths also that psoriasis only affects people physically. The fact is that people with psoriasis, they often experience the stigma and discrimination and exclusion. One of the myths is that psoriasis imposes low cost on people and society. The fact is that psoriasis requires a lot of effort and a lot of also follow-ups with the doctor, so it could be considered a bit time-consuming. One of the myths is that psoriasis is caused by poor hygiene. The fact is that psoriasis has nothing to do with the hygiene. Okay, so the third aim of World Psoriasis Day is to improve the access to treatment. Axios provides 2 access to treatment programs to the patients to support them, especially those who have faced affordability barriers in obtaining their medications. We have two programs, Shukran program. As my colleague Marwa mentioned earlier, that Musanada program is it increases the access to Cosentyx for patients, and to be financially eligible for the program, the patient should be either not insured or has no coverage with the insurance, or insured with a budget limit. Shukran program, it's designed for those who have co-payment insurance, but they cannot cover their share with the co-payment. The fourth aim for World Psoriasis Day is to give the psoriasis community a voice. And here comes the patient's role. Many people, they live with the psoriasis, they struggle to get the world to listen to their needs. So World Psoriasis Day, it's an opportunity for everyone to speak up in any platform for their voice to be heard. We have these hashtags that can be written in the different platforms to share the stories and for the society community voice to be heard. So everyone is encouraged to write their story and share how they feel using these hashtags. Now we would like to welcome our guest speakers. We will start with Dr. Kirthi Raju, a consultant rheumatologist in Aster Clinic. She will share her slides regarding the psoriatic arthritis. Dr. Kirthi? Dr. Kirthi? Dr. Kirthi?
Hi, Asma, I don't think so. I see her name in the participant.
It's Lithu Suri. Okay, till Dr. Kirthi can join us, we can just move on. We can move on with Dr. Vigil, Rosemary Peter, a specialist oncologist. She will share her slides regarding the psoriasis in women in a bit. Dr. Vigil, can you hear me?
Yes, I can hear you.
Okay, doctor, the floor is yours.
Yes, yeah, thank you. I need to take this minute. Take this minute. Okay. Thank you for the introduction. I'm very happy to be here today with you to share some of the aspects of psoriasis, especially pertaining to women. So psoriasis, as I'm sure all of you are already aware, it's a chronic inflammatory disease due to a complex immune reaction. And it can be influenced by genetic factors, which is why many patients with psoriasis have a family history of psoriasis. And there are many triggers in the environment which could act as a starting point for the appearance of psoriasis, like stress, infections, certain medications, smoking, alcohol, changes in the diet, allergies to almost anything, and even changes in the weather. And hormonal changes are another important factor which can have a significant impact on psoriasis. And that is where the special course of psoriasis in women comes to light. And psoriasis, as we said, it's an inflammatory disorder. So there is an underlying inflammatory process. So many times psoriasis may not be just skin deep. It can affect other internal systems too, which is why some patients with psoriasis can have metabolic syndrome. That also you must be already knowing: high blood pressure, diabetes, obesity, and high cholesterol levels. It can be associated with psoriatic arthritis, and some patients can have inflammatory bowel disease. Coming to psoriasis in women, psoriasis is said to affect about 3% of the world's population, which is a staggering number, and half of them are women, and most of these women are under the age of 40 years. So immediately it shows us that there are there's a huge number of women in the world having psoriasis whose age coincides with the time in their lives where they may be thinking about pregnancy and childbirth. And these hormonal changes that happen during pregnancy and childbirth can have a huge impact on psoriasis. So in a woman's life cycle, unlike a man's, there are many different hormonal phases, starting with puberty and menarche, when a girl is transforming into an adolescent and a woman, and a surge of hormones comes into her body. So though this is quite a young age for psoriasis to make its appearance, there have been many women who reported that their first psoriasis lesions appeared at the time of puberty, maybe just before or after puberty. Then the monthly menstrual cycle itself, every month there are so many hormonal shifts happening in a woman's body, and for each woman it can be very different. Some may not feel these hormonal shifts at all, whereas for some women the hormonal changes can cause drastic effects on them. You must have heard of the premenstrual syndrome. Just like that, psoriasis can also be affected by these monthly hormonal shifts, and many women say that their psoriasis is at its worst just before the period. Of course, we will be discussing in the coming slides. Again, in pregnancy, the woman's body is flooded with hormones to bring about all the changes for the proper growth and development of the baby, and to prepare the woman for childbirth. And after childbirth, all these hormones are suddenly depleted, and again there is a hormonal shift. And all this can affect the course of psoriasis. And the final phase in a woman's natural life cycle regarding the hormonal shifts is a menopause. Here again, the protective effect of the female hormones is suddenly lost or gradually lost. When the ovaries stop producing the female sex hormones. And again, for many women, this can be the time when their psoriasis becomes worse. Apart from these natural hormonal phases, there can be some instances where the woman is taking hormonal treatment, maybe for hormones for contraception or hormonal replacement therapy after menopause, or some of them could be taking hormonal medications for heavy periods or for irregular periods, and all these can also affect their psoriasis. And menopause, apart from natural menopause, we have what is called the surgical menopause, where the uterus and the ovaries are removed because of some disease affecting the uterus ovaries, and that can instantly throw the woman into a very sudden form of menopause, which can also trigger psoriasis in some women. So of course, the main and the most important focus when we talk about psoriasis and women will be psoriasis and pregnancy. So any woman who has had a diagnosis of psoriasis and has been on treatment and gets married and is thinking of starting a family sometime will have many questions on her mind. And some of them may be things like, what is the ideal time to conceive? Will I have difficulty if I try to conceive? Will I take longer to conceive? Or will I need to take treatment to conceive? What are the precautions I should take before thinking about conceiving? And what about my medication? Should I stop all the medications? What will happen to my psoriasis if I stop? What will happen to the pregnancy if I continue? All these questions. Will psoriasis cause complications when I get pregnant? Will the pregnancy make my psoriasis worse? And what are the chances that the child can have psoriasis? That is something which weighs very heavily on the minds of many women. In fact, for many women, this may be the main concern, that, I have psoriasis, and what if my child gets psoriasis? I don't want that to happen. So we will just try to discuss these areas of concern one by one. In short, concerning psoriasis and the fertility of the woman, there is no evidence that psoriasis decreases the fertility potential of a woman. They can conceive apart from, provided there are no other factors affecting the fertility. Psoriasis in itself does not reduce fertility. But still, we see that pregnancy rates are lower in women with psoriasis because many of the patients with psoriasis and psoriatic arthritis tend to delay their pregnancy, maybe because of ongoing treatment or the severity of the disease, but mainly because about the concerns about the impact on the baby. In short, about the risk to the baby, if only one parent is affected with psoriasis, then there is only a 10 to 15% chance that the baby will be affected. This means to say that in 80 to 90% of the cases, the child will not be affected by psoriasis. The odds are very good. If both parents are affected, then the risk for the transmission to the child increases a little bit. It's around 50%. If both the parents do not have psoriasis and if only one sibling has psoriasis, then again the risk is around 10 to 15%. And when we talk about the risk of transmission, it means that the child inherits the genetic potential to get psoriasis, but it is not necessary that they will develop psoriasis in their lifetime. They can pass through their entire life without developing it also, even if they have inherited the genetic potential. So one of the main points when we talk about psoriasis in women from the childbearing age group is that unplanned pregnancy should be avoided. So if they are on medications which are known to be harmful to pregnancy, then they should take great care to avoid any unplanned pregnancy. And that is by using some effective form of birth control or contraception. And any form of contraception can be used in women with psoriasis, including the hormonal contraception. In fact, for some women, when they use a hormonal contraception, there may actually be an improvement in their symptoms. So yeah, it should be a very carefully planned pregnancy, and any woman with psoriasis who is on treatment, who is planning for a pregnancy, should inform her dermatologist or rheumatologist that about her plans. So they will help her. They will help her to to achieve the maximum disease control with the appropriate medication, so that she is in the most ideal situation at the time of conception. Yeah, so when the woman is conceiving, she should preferably have her psoriasis in a controlled and stable condition, and all the medications that can potentially harm the pregnancy should be stopped and should be changed to safer alternatives. Or some women, for some women, it may be possible to stop all the medications. Yeah, so that would be the ideal time to conceive. For some women, especially those with severe psoriasis, which is a minority, most of the cases are mild to moderate psoriasis, but for some, it can be severe, and treatment discontinuation could be impractical. So this is the time when the doctor will try and weigh the risk and the benefit of stopping or continuing the treatment. So if the psoriasis is uncontrolled and severe, the severe inflammatory process itself can harm the pregnancy and the child and negatively affect the outcome for both the mother and the baby. So in those cases, it is better to continue the treatment in spite of some risks. So that decision will be taken by the doctor. Then as for any other woman who is planning to conceive, psoriasis patients should also be on preconceptional folic acid, but they need high dose folic acid. First of all, because the cell turnover in their body is quite high, and some of them may be undergoing phototherapy, which can decrease, like either PUVA therapy or ultraviolet B therapy, which can decrease the folate levels in their body. And folic acid is very important for the development of the nervous system and spine of the baby in the early weeks of pregnancy. So even before she gets pregnant, the woman should be on high dose folic acid. To all women who are planning to conceive and who do not have immunity to rubella or chickenpox viral infections, that the immunity can be checked by doing simple blood tests, we advise rubella and chickenpox vaccination so that they don't get these infections during pregnancy. Because outside of pregnancy, they may be mild infections, but in pregnancy, it can have disastrous effects. So we always advise these vaccinations to any woman who comes for preconceptional counseling. So the same holds true for women with psoriasis. But those women who are on any kind of immunosuppressant medications, like steroids or biologicals, should be careful while taking these kind of live vaccines. Maybe the medications should be stopped, and only after that these vaccines should be given, because live vaccines should not be given to those who are on medication suppressing the immunity. So we are talking so much about stopping medications, changing medications, harmful medications. So what are the, just a short discussion about the medications. The group of medications called retinoids or retinoic acid derivatives like acitretin and isotretinoin, maybe many of you have heard of it. These are extremely harmful to pregnancy. And in fact, the degree of harm is so much that after discontinuing these medications, there should be a gap of 2 to 3 years in some cases before attempting to conceive. Methotrexate is another medication which is mostly used in psoriatic arthritis, which is extremely harmful to the pregnancy. And this also should be discontinued for at least 3 months, 3 to 6 months before conception. And this holds true not only for the women, but also men who are on methotrexate. Before they are planning a baby, they should stop the medication at least 3 months before. Steroid medications, some of the patients may be on steroids, especially again if they have psoriatic arthritis, and it can be harmful in the first 3 months of pregnancy. In the later stages of pregnancy, it is not so harmful, but still it can have effects like increased incidence of high blood pressure and diabetes and low birth weight baby and premature delivery, etc. Cyclosporin, it is one of the safer alternatives. It's not completely safe. It does have some effects, but it is a safe alternative which may be considered by the doctor if there is resistant psoriasis lesions. Coming to the newer groups of drugs, the biologics, which is the latest and a very good treatment, I believe, for psoriasis. Since there are medications which suppress the immune mechanisms, it is better to discontinue. But having said that, there have been cases where women have become inadvertently pregnant while they have been on the biologicals. And for some, the disease is so severe that they have to they are pregnant. And in these anecdotal situations or in these case reports, there has not been any evidence of any significant harm to the baby and to the pregnancy. But of course, it would not be a choice to continue, but it is encouraging that there are no adverse effects, there have been very few adverse effects reported till now. In the case of biologics, even if they have to be continued during the early part of pregnancy or just or during the preconceptional period, they are not to be used in the later stages of pregnancy, because during the later stages they cross the placenta and enter the blood of the growing baby, and they reach very high levels in the baby's blood. So when the baby is born, the baby can have decreased immunity and increased risk of infections. So that is why generally the biological are totally avoided in the last 3 months, in the last 3 to 4 months of pregnancy. And also in such babies, care should be taken from not that they should not have the live vaccines like BCG vaccine, which is a first vaccine which is given to most of the newborns. So in these rare cases where the baby has been exposed to biologics, they should not be given live vaccines. And also some diarrhea vaccines or rotavirus vaccine should also not be given to these babies. PUVA therapy is also generally not continued during the pregnancy. So in pregnancy, of course, profound hormonal changes occur, and these hormonal changes, they cause many alterations in the immune system also. Why this happens? This is because the baby growing inside the woman is genetically half from the woman and half from the partner or the husband. So technically, half of the genetic material in the baby is foreign to the woman. So the fetus or the baby can be perceived as a foreign organism, and the immune system of the woman should adapt to accept the baby as self and not reject it as foreign. So the hormonal changes in pregnancy help to suppress any such negative immune mechanism against the baby. This helps in psoriasis patients because when the immune mechanisms are suppressed, the immune reaction which is occurring in psoriasis is also suppressed. That is why 50 to 60% of the women with psoriasis improve during their pregnancy. And in many of them, even if they have been using some medications, they can be stopped. And quarter of the women don't show any change, and only a quarter of them showed worsening of their symptoms. So it's very individual variation is there. For some women, it can worsen also, but in almost 75% of the cases, there is either improvement or no change. Generalized pustular psoriasis, that is a very rare form of psoriasis which occurs in pregnancy, which is, fortunately it's very rare and it's also unpredictable, and it may even occur in women who have no prior history of psoriasis also. Most of the cases of psoriasis are mild to moderate. And the good news is that in mild to moderate psoriasis, there has been no evidence of any increased risk of complications. So they can, it just goes forward like any other pregnancy, with only minor problems that are easily solved. But in severe psoriasis, because of the underlying inflammation, it can give rise to high blood pressure problems during the pregnancy, premature delivery, and birth of a premature baby, and low birth weight or poor growth of the babies. And to reduce the incidence of these complications, appropriate treatment of the severe psoriasis is needed, because only if the inflammation is controlled, the complications also will be less. If the patient has psoriasis in the genital area, then she should inform her obstetrician so that the doctor can plan the delivery in such a way, whether it's normal delivery or cesarean, to minimize the injury during delivery in that area. We have something called Kepner's phenomenon, where any cut or injury to the skin during delivery, either during cesarean or the cut during normal delivery, the psoriasis flares up in and around that area. So that is one of the things that can happen during the delivery process. Vitamin D deficiency is known to make psoriasis worse. So all the pregnant women should get their vitamin D levels checked and correct any deficiency so that they can have an optimal outcome. After childbirth, a sudden reversal of all the hormonal changes, and whatever protective effect was there for some women is suddenly lost. Added to that, childbirth itself is so exhaustive, and the woman is completely tired, and caring for the baby, feeding for the baby, disturbed sleep, lot of stress. So the hormonal loss along with the stress can cause a flare-up of symptoms in many women. Even those who have proved during the pregnancy can have a flare-up after the delivery. And can also be a trigger for psoriatic arthritis. Many women who never had psoriatic arthritis before, for them the delivery period can be the starting point. And if the symptoms are severe enough to start treatment, then treatment should be started. And many of the medications which are safe during pregnancy are also safe during breastfeeding. In fact, it is safer during breastfeeding because the amount of medications that is passing through the breast milk to the baby is usually very, very minimal. Whereas in pregnancy, the medications pass through the blood, through the placenta, and through the blood to the baby. So it is the transfer is higher, but through the breast milk, the transfer is much lower. So at this time, the new mother needs a lot of support from, especially most importantly, from her partner and also from her family, any helpers around. She should get adequate rest. She should learn to take rest when the baby naps. She should nap. She should take care of her diet. In spite of all this, some women can also develop the psoriasis lesions on their breast, which can hamper the breastfeeding. So creams can be applied over these lesions, but the woman should take care to apply them after the breastfeeding of the baby, and remove it before the next feeding session. Psoriatic arthritis is thankfully rarely seen, and just as in psoriasis, mostly psoriatic arthritis improves in pregnancy, but some women can have psoriatic arthritis involving the spine, the pelvis, and the hip joints, and as the pregnancy advances and the uterus is growing bigger and the abdomen is growing bigger, it can cause a lot of pressure and stress on these joints, and it can make their symptoms worse. And also, the involvement of these joints can hamper the delivery itself. It can hamper the administration of spinal anesthesia or epidural anesthesia, which is an injection given in the spine during delivery to reduce the pain, or during cesarean for the purpose of anesthesia. So all these complications can be there, and the doctors will have to plan accordingly or modify accordingly. Psoriatic arthritis can also, just like psoriasis, it can worsen after the delivery, and some women may even have trouble holding the baby while they are breastfeeding. So treatment will have to be started in these patients. So that was about psoriasis and pregnancy and childbirth. Coming to menopause, as we already discussed, the protective effect of the female hormones is lost. Added to that, the stress of the menopausal symptoms, hot flashes, insomnia, depression, anxiety, weight gain, vaginal dryness, mood swings, lot of stress even without psoriasis. Added to this, when there is underlying psoriasis, it can be a trigger for the worsening of psoriasis. And in these women, vitamin D deficiency can worsen the symptoms just as in pregnancy. So this may be a time when many women may have to restart their treatment. And starting the hormone replacement therapy for the menopausal symptoms, it may help some women with their psoriasis also. Psychological factors definitely play a big role in psoriasis, and it was seen that impaired quality of life, unhappiness, stress, loneliness, and stigmatization were seen more frequently in women with psoriasis than in men. And any situation of stress can aggravate psoriasis. And low self-esteem and anxiety are very common. And it can also lead to major psychological symptoms like depression, and they may need to get the help of a mental health expert. Pregnancy itself causes a lot of stress and frustration, and for some women it can change their perception about their body image and lack of acceptance about the changing appearance, and the psoriasis lesions may itself be causing a lot of discomfort. It can lower the mood and cause depression and anxiety, and that should also be tackled with, if it is severe enough, with a psychologist or psychiatrist. And support is very, very important, whether it is the partner or the mother or the friends. All of them can play a big role at this time to comfort the woman. Apart from this, she can follow a healthy pregnancy lifestyle by following a balanced diet and getting enough rest and adequate exercise. And she can practice some relaxation techniques. All these may help. Though there is no specific diet recommendation for psoriasis, there have been a lot of foods which are supposed to be anti-inflammatory foods. There are a host of foods that can help with psoriasis. It differs for each person. What is scientifically proven is that there is a slightly higher risk of developing diabetes and cardiovascular disease in patients with psoriasis. So regular exercise and healthy diet is going to reduce the risk of these conditions. And exercise and good diet can also reduce stress, which can help to improve the psoriasis. So this applies to women with psoriasis also. Thank you.
Thank you, Dr. Vigil, for this informative presentation. I believe Dr. Kirthi, she has joined us. Dr. Kirthi, can you hear me?
Yes.
Yes, doctor. The floor is yours.
Are you able to see the PPT now? The PowerPoint?
Doctor, I think I would share it from my side.
Okay, because I'm not able to load it.
Yeah, sure. I will share it from my side.
Good morning, everybody. I would like to congratulate the Axios team, Dr. Sri Kumar, and the others for taking the efforts on improving the awareness about psoriasis and its implications. As you all know, it's very important to be aware of it. The treatment begins there, and that's where we are able to make a difference. So we've had quite an elaborate lecture on psoriasis in pregnancy and all those stages which are quite stressful for women. So most of the concepts about the etiology and the management has been covered. There's nothing much for me to share except for some insights into psoriatic arthritis, because the skin and the joint is common to the inflammation of psoriasis. I'm not able to see the presentation as Zora.
Yes, I'm trying to share it. One second. Can you see it now, doctor?
Yeah. Slideshow mode. Yeah. Yeah, so as I already said, it's the concept of inflammation which predominantly manifests in the skin and less commonly in the joints. So it's all the same disease with one or more facets of it. So psoriasis has been described elaborately. It's an inflammation of the skin involving the nails as well. And when it involves the nails, it's more correlating to the arthritis. So the common manifestations as in the slide can be the nail involvement or the finger involvement, swollen fingers like sausages, which we call as dactylitis, or tendon inflammation and back pain with the skin psoriasis and the generalized joint pain. So psoriatic arthritis, the most important thing in the management is the awareness. As you see, the predominant age group affected with psoriasis is the 30 to 50-year age group. And among them, only a third develop psoriatic arthritis. So it's very important for all of those with psoriasis to know that there is a chance for them to have an inflammation in the joints, and in case that occurs, it should alert them, and then they could mention it to their dermatologist and accordingly be routed to a rheumatologist who can help their joints. The challenge is that they are already on medications for psoriasis. Most of the psoriasis are mild and that can be managed with topical medications, but few of them develop few of them it's severe and they need internal medications. So when they develop joint pains while on an internal medication, it signifies that it's important and it's not able to surface because already there is a medication which is going on and which is not allowing it to express entirely. But in the due course, it could evolve into a full-fledged psoriatic arthritis. So it's very important to identify it at the early stage, and that comes with awareness that your joints can also be sore. The other thing about knowing about psoriasis, previous slide, Zora, once again, the previous one. The other thing is when you have psoriasis, it's also important to be aware of the fact that if you are having a skin psoriasis, another member can develop joint pain due to the psoriasis without involving the skin. So if you see, very few of them can develop arthritis in the absence of psoriasis. And that's what this 40% mentions, that 40% will have a family history of psoriasis. And unlike the other forms of arthritis where women tend to be more affected than men, in psoriatic arthritis, it's nearly equal in proportion. Men and women are equally affected. Yeah, so in the next slide, what would be seen is that psoriasis tends to affect the musculoskeletal structures. By musculoskeletal structures, we mean the joints and the tendons which are around the joints. So when the joints are involved, you get swollen tender joints. And when the tendons are involved, particularly in your feet, your heel, the Achilles tendon, that can be inflamed, or rarely you can have this elbow pain manifesting as tennis elbow. Yeah. So, as I said, psoriasis is a concept of inflammation which generally involves the skin, but next commonly involves your joints, and rarely it can involve the other organs, the eyes, where it manifests as uveitis, where you have painful red eyes with blurred vision, or can manifest also as an inflammation of the gut, which is called the inflammatory bowel disease, where they have stomach pain, abdominal pain, loose stools, bloody stools. So the main thing about psoriasis, it's a concept of inflammation in your body, which can involve other important organs as well. So this awareness is very, very important in understanding and handling it so that the damage due to the inflammation could be minimized. The other thing which I would like to bring about is psoriasis is an inflammation. And currently we are all aware about high blood pressure, high sugars, diabetes, and high cholesterol. And the moment we know, we all become aware, and then we are concerned about our heart and try to keep all those parameters under control so that our overall health is well maintained. The same applies for inflammatory diseases also. Psoriatic is one of them. And if the inflammation in psoriasis is not controlled, then it can lead to cardiovascular issues, and the major brunt of the vascular diseases either on your heart in the form of a coronary artery disease, the layman's term, the myocardial infarction, or stroke. So as important as a diabetes or a high blood pressure is for a heart, control of inflammation of psoriasis and psoriatic arthritis is very, very important. And it comes under the category of systemic disease. So this has been talked about in detail with regard to the causes of it, a suitable genetic background, and with an overactive immune system, and an adequate trigger, environmental factors, stress. And Dr. Vigil has spoken well about the various stressful factors in a woman's a woman goes through pregnancy, postpartum, menopause, and these are the most important phases where we get triggers of psoriatic arthritis. Many times it happens that a lady has a well-controlled psoriasis, but during one of these phases, due to the enormous stress, the arthritis evolves. About the common triggers, again mentioned, emotional stresses, infection, then trauma, particularly mechanical triggers can trigger in the inflammation in the joints. And then medications, a couple of medications are there, but common being the beta blockers, which are used to treat high blood pressure, and your ACE inhibitors also used for control of high blood pressure. So this is about the psoriasis to psoriatic arthritis transition. As I said before, not all with psoriasis will develop psoriatic arthritis, but nearly 1/3 of them. And this, again, all these factors, your genetics, the triggers, all of that. So if you keep your psoriasis well under control by adopting a healthy lifestyle and minimizing your triggers, then probably we would be able to limit or prevent the emergence of an active psoriatic arthritis. Regarding the symptoms of psoriatic arthritis, the most important thing, it's about joint pains, joint stiffness. Any joint can be involved, the fingers, wrist, elbows, back, neck, knees, feet. Stiffness is quite more in the morning when they get up, and it eases as the day goes by. Tenderness over the tendons with a lot of pain and swelling, called as enthesitis. Then sausage-like enlargement of fingers or toes, we call it dactylitis. Again, back pain due to the involvement of the joints of the spine. And of course, there'll be a reduced range of movement in the affected joint, along with nail problems. And fatigue is also an important complaint. This is a result of overall inflammation on the body, affecting through the muscles. And eye problems due to uveitis. There are different types of psoriatic arthritis. The common one is the distal psoriatic arthritis, where the terminal joints of the fingers or toes are affected. Then you have the spondylitis. We call it spondyloarthritis because it involves the joints of the spine, and this can manifest as back pain with stiffness, more so in the morning, eases as the day goes by. It's seen in 5%. It forms 5% of the psoriatic arthritis. So in one with psoriasis, with a recent onset low back pain, with a lot of stiffness, more in the morning on waking up, it should alert you whether it's a psoriatic arthritis. And that will help you to contain it at the early stage. Again, there's a bit aggressive form of joint involvement called arthritis mutilans, where the joint, due to inflammation, progress is very fast, to the extent that the digits get eaten up and they become short, or in other words, mutilated digits. We call it arthritis mutilans. This is also quite rare. The next one is enthesitis, which clearly shows the Achilles or the heel tendon being swollen and minimally inflamed. This is one of the manifestation, and the last is the sausage-like enlargement of the toe. We call it dactylitis. And in this figure, you can see the second toe of the right foot being swollen and enlarged. So these are the different types of psoriatic arthritis. Treatment depends on the type as well. That's why it's important to know what is the type of psoriatic. Some may just have one type, one may have more than one. Rarely somebody can have all the 5, and they are the ones who are very severe and they need the aggressive treatment. Again, this shows the joints inflamed. Like if you see the upper left one, the index finger of the right hand is swollen at the middle joint. And the index finger of the left hand is swollen at the terminal joint. We call it DIP arthritis. In the upper right, you can see the right ring finger and nearly all the nails being affected with psoriasis. This again signifies severe disease. Again, in the hand, the lower left picture, you can see the index finger of the left hand again having the sausage appearance. And in the right hand, most of the terminal joints or the DIP, distal interphalangeal joints, being inflamed. In the lower right, you can see the sausage-like enlargement of the fourth toe of the right foot and the third toe of the left foot. So this picture just depicts the various forms of joint inflammation, particularly in the extremities of the hands and feet. So how do you diagnose psoriatic arthritis? Besides the clinical features, knowing the symptoms, then the examination by the specialist, there are a couple of diagnosed labs which are required. We do the baseline rheumatoid factor and the anti-nuclear antibody to make sure that we are not missing any coexisting rheumatoid arthritis, because rarely more than one type of inflammatory arthritis can coexist. Along with the baseline parameters, this is mainly to start our medications, and the uric acid level. This needs a special mention because those in the levels of uric acid tend to be higher in those with psoriasis and psoriatic arthritis. So many a times it's a challenge whether the joint inflammation is due to psoriatic arthritis or due to uric acid, or in other words, gout. But putting together all the clinical features and the investigations, we conclude and accordingly treat. Rarely they can present with swollen joints, more commonly the knee or the wrist. And particularly when the knee is swollen, then we take out the fluid from the joint and analyze it. More so required when there is a single joint involvement, like a single knee, where there's a doubt whether it's a gout or a psoriatic arthritis. Of course, x-rays are helpful. In early stages, x-rays would be normal, but in those with advanced disease, they would show the changes. MRI, this is a very important scan. This is one which will help in early diagnosis of an underlying psoriatic arthritis, because x-rays would show the established changes where the scope of treatment is less. But the MRI is the imaging modality which will help us to recognize the joint inflammation at a very early stage, so that we could initiate our treatment at the earliest and minimize the damage and control the inflammation. So the MRI is the thing which will help us to get a hold of the disease in its early phase. Regarding management of psoriatic arthritis, a lot of it has been dealt with in detail by the previous speaker. As in any condition, lifestyle measures and medications. With regard to lifestyle measures, as you know, it's very important to stop smoking, because smoking would reduce the efficacy of the disease-modifying drugs or the main medications which are used to treat psoriatic arthritis. Next slide. It's very important to limit your servings of alcohol. It's not possible to ask one to abruptly stop, but we can advise them to gradually reduce it. Other than that, decrease your mental stress and adequate physical activity. I would need to mention about the psoriatic arthritis diet, because reduction of weight is one of the important things in reducing the inflammation of psoriasis. They say that a weight reduction by 5% helps to reduce the activity of the disease in those obese people with psoriasis or psoriatic arthritis. Diet-wise, the major contribution of diet comes in reducing the weight and thereby reducing inflammation. Anti-inflammatory diet per se doesn't have much of a say other than reducing the inflammation. But still there is a mention about certain foods to be avoided and certain foods to be promoted. So you need to avoid, the previous slide please. The foods which need to be avoided are those which are rich in sugar, like the pastries and the aerated drinks, then high fat meat and refined carbs like pizzas, pastas, breads, white breads. Foodstuffs which need to be encouraged are fruits, with all sorts of fruits, particularly those who have an edge of anti-inflammatory effect, particularly the berries, then inclusive of vegetables which are rich in fiber, again are anti-inflammatory. Encourage the use of nuts. Nuts also optimally, because overuse of nuts can increase your uric acid as well as can increase your weight. Then we encourage the use of whole fiber cereals, and also fish, which is rich in omega-3, and other vegetable products as well, which are rich in omega-3. The next slide is about obesity, where reduction in the weight contributes very much to reduction of inflammation. An increase in weight is known to trigger flares. Regarding the medications for psoriatic arthritis, we have three groups of medications: the non-steroidal anti-inflammatory medications, the disease-modifying drugs, and the biologics. In the next slide about non-steroidal anti-inflammatory medications, you see there are multiple medications available. We have naproxen, ibuprofen, celecoxib, diclofenac. The choice of the anti-inflammatory would be based on the comorbid conditions like history of asthma, underlying fatty liver, gastroesophageal reflux disease, and the other cardiovascular mortality and morbidity factors. For example, in one with a fatty liver, we wouldn't prefer Voltaren, we would prefer Celebrex. And in one with asthma, we would again prefer a selective COX-2 rather than a non-selective medication. With regard to the disease-modifying drugs, in the next slide, disease-modifying drugs are the cornerstone in the treatment of psoriasis and psoriatic arthritis. The common being methotrexate. It's a weekly dose, quite effective, not advocated during pregnancy, and to be withheld 3 months prior to a planned pregnancy. If there are issues with methotrexate, then leflunomide would also be used, more so in psoriatic arthritis. Then sulfasalazine is another drug which is preferred, but it's usually effective in mild psoriatic arthritis. With advance in technology and more developments, we have the newer category of drugs called the biologic DMARDs, which are in the last 20 years. There are a variety of options. The upper left being the Enbrel, which was one of the first drugs, first biologics to be available for nearly the last 20 years. Next came the Remicade, then the Humira, and now we have other newer medications like Cosentyx, Taltz, and recent guidelines have included some oral medications like Xeljanz or tofacitinib, and another medicine, the Otesla, the apremilast. The advantage of apremilast is apremilast compared to the other medication in this group is that we don't have to screen them for infections like TB, which are mandatory prior to the other biologics. This is just in a summary about the manifestation, about the treatment of different types of psoriatic arthritis. The left one about the skin and nail that has been dealt in detail. Regarding the axial disease or the spondylitis related to psoriatic arthritis, the treatment is anti-inflammatory medications with physiotherapy. And if this doesn't get controlled with this, after observing for nearly 3 to 4 months, then we'll have to switch with our higher treatment. Then we would need to go with the biologic disease modifying drugs. Regarding the peripheral arthritis on the lower right, we can continue with our protocol, begin with anti-inflammatory medications, and if it's confined to 1 or 2 joints, we can have a targeted injection in one of those painful joints. And if it's still persisting, then we go with the conventional disease modifying drugs, which I described, methotrexate and leflunomide. Those of y'all who are taking these medications about them better. Then lower down, we have the enthesitis, which is also managed similar to the spondylitis with painkillers, physiotherapy, and then biologics. Then we again have the sausage-like dactylitis, which can be managed with similar to the peripheral arthritis, like painkillers, steroid injection, and I definitely use a disease-modifying drug before going for a biologic. So this is an overall management of psoriatic arthritis. Next. Regarding flares, this is very common. In one who has a controlled disease, there can be a flare. Symptoms being fatigue, rashes, worsening rashes, joint pain, swelling. Again, stresses, causes being stresses, injury, skipping the medication or unhealthy lifestyle. Treatment, readjust your medication, escalate your physical activity, reduce your stress, and include a holistic lifestyle. Next. Before concluding, I would like to emphasize about the cardiovascular risk. Psoriatic arthritis has a profound effect on your overall system, and it increases your risk for obesity, hypertension, diabetes, dyslipidemia. And the inflammation due to psoriatic arthritis per se can increase your atherosclerosis. So directly, it can increase your atherosclerosis, and indirectly, by increasing your cardiovascular risk factors, it can overall increase your risk for cardiovascular disease, myocardial infarction, and stroke. So before I conclude, I would like to summarize that psoriatic arthritis is a systemic disease involving inflammation of the skin, joints, and other organs like your eyes and gut, with an increased risk, which has an increased cardiovascular risk as well, and hence the key to minimize the damage directly due to psoriasis or indirectly due to its cardiovascular risk would be to control the inflammation, have an optimized treatment by having a good rapport with the physician who is treating, have your regular follow-ups with them, include a holistic lifestyle, so that we could beat psoriasis and its consequences and have a near normal lifestyle and avoid the damage due to the disease. Thank you.
Thank you, Dr. Kirthi, for your informative presentation. Now, last but not least, we would like to welcome Dr. Siri Kumar to hear his remarks and his inputs.
Thank you, Axios team and Deepa. Of course, I will go into the detailed thank yous in the end. Just before I conclude, if Lovella is there logged in, are you there, Lovella? Can you unmute yourself and speak to us a bit?
Yes, hi, doctor.
Yeah. Lovella, can you just tell us what you have been through? I know that it's quite a difficult task, but we would all love to know how you have gone through this issue.
Yeah, actually I had my psoriasis since 2005, so I'm having for 5 years now, and thankfully I tried phototherapy. I tried some of the topical ointment, but unfortunately it didn't make it didn't get better, and then thankfully I found Dr. Srikumar, so he decided to try biologics on me, and that's Cosentix. So I'm taking Cosentix for exactly a year now, and it's really working well for me. And unfortunately, early this month in October 13, I am infected with COVID-19. So I was in isolation for 17 days today, and just right in time, I am tested negative twice, so I can go out today. It wasn't an it. I really feel all the symptoms. Maybe because my theory was because I am diabetic. I mean, I'm having high sugar, and but my diabetes is I got it from it's genetic because I got it from my dad. And then psoriasis, I don't know where I got it, but I can't find the history from from my genes or from my family, so I don't know. But so that could be one of the reason why I had all the symptoms, because I think Cosentix lower my immune system as well. I'm not sure, but this is what my theory is. So I suffered all the symptoms. I had cough, I had some fever for the first 2 days. I suffered over fatigue as well. I have some diarrhea during the whole 14 days. And luckily I didn't have shortness of breathing, but I have some cough. And every time it's a dry cough, and then I have some chest pain once in a while, but then thankfully I fully recovered. So I don't know, so even if I think even if you're taking Cosentix and you have this COVID, most likely we still can recover.
Thank you, Lavella. In fact, we had three of our biologics patients who developed COVID, and by God's grace, all of them have recovered wonderfully. So I actually am very thankful for Lavella to be actually bold enough to share her story. As we all know, that we are in a really crazy situation with the COVID pandemic right now. And worldwide, all the organizations have come up with recommendations on how to treat psoriasis patients with biologics, for example. So the one of the common, simple ways of putting it is, in fact, the biologics seem to be far better than the conventional broad immune suppressing medications like cyclosporin, methotrexate, and steroids. So as compared to those kind of medications, biologics seem to be far safer. And overall, the world seems to, in real life evidence, is that patients on biologics seem to recover pretty well from COVID. There is no increased risk of getting the infection as compared to the general population. Any worse outcome. So far, the outcomes seem to be better, like what we have seen in our patients. Of course, this is not a company statement, nor have formal studies been done. But then this is what has been observed worldwide. In fact, Lavella had a dactylitis and arthritis too. And I have had situations where I have had to discuss with Professor Lebuhol in the US and all that about when we actually restart a biologic, when a patient recovers from COVID, And we don't have clear answers, but then he said that wait at least a month after 2 negative tests, and then again reevaluate the patient and decide whether the patient really needs this treatment, and then start. So anyway, I'm really thankful to all the speakers. I'm very, very thankful to Deepa for being a wonderful organizer. And of course, the entire Axios team. I'm thankful to Asma. I'm thankful to Marwa, Lina, Rafa. In case I've forgotten anybody's name, please excuse me. Each and every one of you put in a huge effort, and our program has been extremely successful. And I know that we have a wonderful community of patients with psoriasis with us, and our psoriasis support program has been supporting each other. So as we all know, psoriasis is a multidisciplinary condition. I would say that it's a community issue. See, it's not that it's not a single doctor. We need the dermatologist, the rheumatologist, the physician, the gynecologist, the pediatrician, the psychiatrist. We have a lot of people who play a role, be it the yoga teacher or the lifestyle guru, or in fact even the community of patients who need to support each other. Therefore, this is one of those conditions we need to hold hands. Spreading information is a very, very important point. So we need to spread the information that psoriasis is not uncommon as you think. Nearly 4 to 5% of the population may be having it. We need to inform everybody that it's not an infection that spreads from one to another. We need to tell people that nearly 1/3 of the patients with psoriasis can have issue with joint swelling and pain. We need to talk about the obesity, the diabetes, the inflammation in the intestine and the eyes, and the psychological impact that psoriasis can have. We need to talk about the various lifestyle needs and adaptabilities according to age that one has to go through with psoriasis. Psoriasis does occur in the pediatric age group. It affects schooling, it can affect education, work. So it can affect relationships. We know that psoriasis in sensitive areas in the face and hands and visible areas can be more severe, even though it may not involve the entire body. We also know that psoriasis in the genital area and all that can lead to sexual impairment and difficulty in forming relationships. Marriages have been broken due to psoriasis. So psoriasis in the skin is just the tip of the iceberg, and the myriad facets of psoriasis and all its implications, and the fact that psoriasis is one of those conditions which unfortunately involves a lifelong care and a huge commitment in time and money. The cost of treating psoriasis actually to the community and to governments can be far more than that of treating heart attacks, stroke, or a major road traffic accident and cancer. So you can imagine the amount of money that people have to end up spending if they end up getting severe psoriasis. So this is one of those conditions which cries for a support group. And I'm very glad that we have been running a very successful support group. Today, in particular, I need to thank both Dr. Kirthi Raju, a consultant rheumatologist, who actually took time to speak to us about the arthritis and the various facets of arthritis. We know that arthritis can come many years after psoriasis in the skin comes. Sometimes it can come together, sometimes very rarely it can come even ahead of time. And Dr. Kirthi, as a consultant, said that sometimes more than one type of arthritis may be there in a patient. The huge functional impairment and pain and all that it causes a patient is all well known. Therefore, I'm very, very thankful for Dr. Kirthi to have consented and given us a beautiful talk on psoriatic arthritis. Of course, Dr. Vigil was definitely a star today. We rarely talk about it, but the impact of psoriasis in pregnancy, getting pregnant, facing pregnancy, post-delivery, breastfeeding, taking care of children, the psychological fear that psoriasis being a genetic condition might affect the children, the anxiety, the depression as it is associated with pregnancy, and then on top of it psoriasis and psoriatic arthritis, and the impact psoriasis has during menopause, and the impact psoriasis has forming relationships and getting married. All these are very important aspects. As she mentioned beautifully, luckily during pregnancy, most of the time psoriasis sort of reduces on its own. Only rarely does it flare up, but post delivery it can flare up. And there is an unusual form of psoriasis called generalized pustular psoriasis of pregnancy, which is quite a horror to get sometimes. But believe me, nowadays we can treat it far better. In my time, I have seen women actually, in fact, mortality is possible. So it's one of those horrendous forms of psoriasis, pustular psoriasis, which can take the life of a pregnant lady. Therefore, we need to discuss psoriasis in all its forms, and without wasting further time, thank you each and every one of you. To repeat, Deepa, the Axios team, Dr. Kirthi, and the Dr. Vigil, of course, Lovella, and all of our psoriasis support group patients. I know that on a Friday, logging into a meeting like this is quite tough. That's why I'm thankful that the meeting is being recorded too, so that in case anybody could not attend the meeting, they can always see the recording. So thank you very much. Thank you one and all.
Thank you, Dr. Sri Kumar, for your input. I would like to also thank everyone who joined us today. It was nice meeting all of you, and I hope we will meet again in another online meeting. Till then, stay safe and take care.
Thank you. Thank you very much.
Thank you very much. Thank you.
Thank you.
Can we leave? Is it done?
Yes, it's done. Thank you so much for attending.